I want to start by thanking Dr. West and everyone here in the room for coming out today. This is a really outstanding opportunity to do live what we do online via Cancer Grace. I've been given a really interesting topic today, which is to identify which patients are going to benefit most from immunotherapy. So we can go ahead and launch into these slides here. There we go. And I actually wanted to start things out with a real conversation that I actually had in clinic last week. John, one of my patient's sons, is actually an outstanding immunologist at a prominent medical research facility in Southern California. I'm always intimidated when I walk in the room with him because he probably knows a lot more about B cells and T cells than I do. But in any case, John says to me, "Dr. Powell, do you have any old tumor specimens from my mom's kidney surgery? She had a diagnosis of kidney cancer, had her kidney tumor removed a couple of years ago." And I said to him, "Sure I do. It's banked. It's in our pathology labs. Why do you ask?" And John says to me, "Well, I'd like you to stain it for PD-L1. We heard a little bit in Dr. Atkins' talk about potentially staining for PD-L1 and how it might correlate to response." And I said to him, "Well, why do you want to do that?" And John said to me, "Well, I'd like you to order lambrolizumab for my mom if her tumor shows high levels." And I'm going to come back to this conversation and discuss with you perhaps some of the rationale for not taking that approach in this particular case. And just as background for those of you in the room, I'm a GU medical oncologist, so these are the cancer subtypes that I see: prostate cancer, kidney cancer, bladder cancer, and testicular cancer. I know everybody in the room has varying research interests, so just for purposes of today's talk, I'm going to focus on kidney and bladder cancer. And these are two diseases where I think that PD-1 and PD-L1 inhibition is particularly relevant. So why don't we go ahead and launch into kidney first. So again, acknowledging that everybody here has some varying interests, I'm going to start with Kidney Cancer 101, and certainly happy to entertain further questions about the disease. My main focus is going to be on treatment options today. But there are about 273,000 cases of kidney cancer diagnosed worldwide annually. The median age at the time of diagnosis is 65. So the other disease type that I treat in my clinic, prostate cancer, has the same median age. We often don't think of this as being a disease of the elderly, but in point of fact, it's true. One thing about kidney cancer that stands out to me against many other subtypes where we see a falling incidence is that the rate of diagnosis of kidney cancer has actually increased by 2% per year for about the past 65 years. And this trend continues. We really haven't seen any diminution in the rates of kidney cancer over the past several years. There are many common risk factors for kidney cancer, and these include smoking and VHL gene mutations. So again, Kidney Cancer 101 here. This is how we stage kidney cancer. This is certainly quite different from how we stage melanoma and breast cancer and lung cancer and other diseases. So I'll go through this with you relatively quickly. But stage 1 kidney cancer implies that the tumor is relatively small, 7 centimeters or less, and really confined to the kidney. Stage 2 disease, it can expand beyond that 7 centimeter dimension. And in stage 3 disease, that's really where we start to see kidney cancer spreading outside of the kidney itself and moving into some of the structures surrounding the kidney, like the vena cava, as you see outlined in this diagram. And finally, stage 4 kidney cancer is where we see the disease move to other organs. Kidney cancer has a strong predilection to migrate to the lungs and to the bones, to the liver. And in terms of the management of kidney cancer, we just had our kidney-specific forum a moment ago. I talked to some individuals who had lower stages of kidney cancer. Stage 1 through 3 disease is really in the hands of the urologist. So that's not typically the disease type that I encounter. The urologist will typically resect tumors, and then the patient is followed with subsequent CT scans and what have you. In contrast, stage 4 disease is really where you're going to be in my clinic as a medical oncologist, and typically the disease is treated with systemic agents. So what's really unique about kidney cancer, and I suppose this is true to some extent in melanoma, is that we've had over the past couple of years a slew of drug approvals, and these represent targeted therapies. So prior to the advent of these targeted therapies, we really didn't have much to treat kidney cancer, unfortunately. The mainstay of treatment was immunotherapy, but very different from the immunotherapy that we're offering now. The principal agent was interleukin-2. Interferon was also used, and we'll go through some of the data for that in just a moment. But again, from 2005 onwards, we've had a number of targeted therapies approved in the clinic. Targeted therapies are also used across several other cancer subtypes. What's quite unique in kidney cancer is that we use these targeted therapies alone or as monotherapy, whereas many other diseases, targeted agents are often combined with chemotherapy and what have you. So what does all of this mean for the patient that I see in clinic with kidney cancer? The bar on the left-hand side of this chart actually suggests what the median survival expectation was for a kidney cancer patient back in 2004. So if a patient walked into my clinic a decade ago, I would suggest to them that the median survival was only about a year. Now, with all of the targeted agents that we now have at our disposal, we've actually tripled survival for kidney cancer. And this is specifically the clear cell variety of kidney cancer, which is most common that I'm referring to. But in any case, we've made some pretty drastic improvements in terms of the survival of this disease with targeted therapies. But of course, I'd suggest that we still have a long ways to go in terms of curing the disease. And that's where some of the novel immunotherapeutic strategies that have been highlighted today come in. So back to the existing agents that we had. So interferon was one of 2 drugs that we used to use for kidney cancer. The response rates to the drug were very, very low. So if you put 100 patients with kidney cancer in a room with metastatic disease and treat them with interferon, you might see a response in maybe a handful, 5 to 6 of those patients. But durable responses, prolonged responses, even amongst those patients, were pretty limited. The median survival, as I'd mentioned before, was about a year with these treatments, and the delay in cancer growth, and what we often refer to as progression-free survival, was only about 4.5 months. So after interferon, it wasn't long before one would need another line of therapy. And of course, the challenge a decade ago is that we really had nothing. Now, this landmark has really been beat by some of the existing targeted agents that I alluded to. With interleukin-2, we have a really perplexing problem. We again have somewhat low response rates. If I put 100 patients in a room and treat them with interleukin-2, you'll see 5 to 7 responses in that room. But the challenge is the drug is also quite toxic. You might have 1 or 2 patients who succumb to toxicity from the drug as opposed to the disease. And in addition to that, amongst those 5 to 7 patients, you may have a handful that have a really long and durable response. So here's the dilemma as I see it from a pictorial standpoint. If I treat patients with interleukin-2, and again, these are the 100 patients that are sitting in the room with kidney cancer here, you're going to have 5 to 7 who are highlighted in green here who have a great response. You're going to have 1 to 2 patients who actually die not from the disease, but from toxicity from interleukin-2, and the vast majority of patients in this room are not going to derive any clinical benefit. So what have we done with targeted therapies for kidney cancer? This is a different depiction of that same room. And at first glance, it looks a lot better, right? So at the top here, you have a number of individuals, about 40 in that room, who are highlighted in green. These folks are going to have a nice response to therapy. Their tumors are going to shrink by 30% or more. In the yellow, we have folks who have stabilization of their kidney cancer. This is, again, another 40 patients in this room of 100 who are going to have their disease not change much with these targeted agents, but perhaps for a prolonged period. And down there at the bottom, we have 20 patients in the room who are going to mount no response at all to targeted treatments. So you can see that these treatments may benefit a broader spectrum of patients, but I think the fundamental challenge is that these drugs only hold the cancer at bay for a certain period of time. In some cases a year, in some cases far less than that. So we really do need novel patients in the clinic. I think the home run here would be if I could predict who could benefit from interleukin-2 therapy. So you recall that there was a group of patients in that room highlighted in green who are going to live for a very, very prolonged period of time. And we embarked on a big study in the kidney cancer community called the SELECT trial. So the intent of the SELECT trial, and one of the leaders of this study was Dr. Atkins, who you met a little bit earlier today, was to treat patients with interleukin-2 and not so much look at their outcome as a whole, but investigate whether or not any features of these patients correlated with outcome. So we used clinical parameters. We looked at their age. We looked at their health status and what have you. None of that seemed to be predictive. We had a good, keen sense that there might be some biomarkers. One that we looked at was a protein called CA9. That didn't seem to be predictive. So I would suggest to you that in 2014, we still can't predict who stands to benefit from interleukin-2 therapy. But today's theme is not these older drugs, interleukin-2 and interferon. We're really here today to talk about some of these novel strategies like PD-1 inhibitors. And again, these drugs harness the body's best weapon against cancer, perhaps, the T cell. And the goal here is to identify, in this talk, who will benefit from these agents. I'm not going to go through the mechanism. I think that that's been outlined very nicely in some of the previous talks. So let's take a look at some of the data that we have in kidney cancer to date. And I would suggest that this is quite different from some of the data perhaps that you've seen in the context of melanoma. This was a trial that was just reported at our national meeting this past June. And this trial took 3 dose levels of nivolumab, a PD-1 inhibitor, and assessed them in patients with previously treated kidney cancer. What we ultimately saw in this study, in my mind, was not a huge delay in tumor growth, but I think some folks in the room have already alluded to the fact that we're not going to really slow down tumors much necessarily on that first or second set of scans. The progression-free survival in this study, or the delay in tumor growth, was in the range of about 2.5 to 4.5 months. What was really quite interesting is that we had some pretty deep and prolonged responses in this trial. So I think we've seen a couple of these waterfall plots earlier today. It's always best to be below the line in these waterfall plots. That indicates some degree of tumor shrinkage. And you see a softer dotted line there at around minus 30%. That indicates that a patient has had what we would consider to be a response to this therapy. So what would really be outstanding in my mind is to identify who these responders are and who these non-responders are. In essence, I would really like to be able to distinguish the reds from the yellows that are shown here on this diagram, and we're going to talk a little bit about that today. I think many have alluded to the fact, and Dr. Atkins mentioned it, that PD-L1 could potentially be the answer here. Again, PD-L1 occurs at this interface between the T cell and what's called the antigen-presenting cell. And that's, in fact, been looked at in a pretty robust fashion. And this is a schematic that outlines that same principle. If we look at this interface between the T cell and the antigen-presenting cell, we see that drugs like nivolumab and lambrolizumab and 3280, all of these work at that interface between PD-1 and PD-L1. So it seems like it would be pretty implicit that the expression of PD-L1 would correlate with response. So we actually have a specific study that aimed to address this in kidney cancer, and this was also reported at our national meeting by my colleague at the Farber. So in this trial, patients went through the same randomization to multiple dose levels of nivolumab therapy, and this study was quite unique in the sense that it used a fresh biopsy at the time of baseline, at the time of study entry, and they did a second biopsy at the time of at the initiation of the second cycle of treatment. And what we ultimately saw was as follows. About 22% of patients that were PD-L1 positive responded, and 8% of patients with PD-L1 negative responded. So this isn't the discrepant response rate that we would perhaps have expected to see. And the argument that I think many would make, including myself, is that this distinction may not necessarily be enough to turn away what we're deeming PD-L1 negative patients from clinical trials, at least in the context of kidney cancer. So again, the key message here is that we may not be able to use PD-L1 status to select the best patients at this point in time in the context of kidney cancer PD-L1 monotherapy. And there are no good reasons to request PD-L1 staining at this time in the context of this treatment. But what about combination therapy? You've heard a little bit about throwing together two immune-based agents in the session earlier. Could PD-L1 status potentially predict the activity of two immune-based agents that are used together in combination? One combination that's moved forward in melanoma, that's also inching its way forward in renal cell carcinoma, is this combination of nivolumab and ipilimumab. And just as previously, I'm going to speak principally towards the data in kidney cancer that we have to date. So whereas you saw that nivolumab will block this interaction between PD-1 and PD-L1, ipilimumab is going to block the interaction between a separate entity called CTLA-4 and B7. So we have a number of combination studies that have been looking at this across malignancies, but again, I'm going to focus on a trial that was done in the context of kidney cancer, looking at this particular regimen. And what we saw was exactly what we would have hoped to see, a lot of really nice, deep responses to therapy. These aren't the sorts of waterfall plots that I'm used to seeing for new agents for kidney cancer. So certainly this data is quite impressive. It looks very promising. But it really outlined the opposite of what we might expect in terms of PD-L1 status. So in this trial, if you actually had high PD-L1 staining, your response rate to the combination of nivolumab and ipilimumab therapy was actually lower than if you were PD-L1 negative. And this was true to an even greater extent if we looked at a different threshold for PD-L1 positivity. So the key message here is if we really don't know about the utility of PD-L1 staining with single agent nivolumab, we definitely know about its utility with the combination of drugs. So I think that the benefit of this is at this point somewhat undetermined. Now, maybe this could be setting specific. So again, one of the cancer types that I treat is bladder cancer. So we're going to shift gears for just a moment and talk about this disease. Bladder cancer really differs from kidney cancer in the sense that we really haven't had the same extent of therapeutic advances. I can't really show you a timeline for bladder cancer because we've really had no new treatments developed for the disease in over 30 years. So PD-1 and PD-L1 based therapy represents a strong potential advantage in this domain. I'm going to talk about a drug called 3280. I think that Dr. Atkins has already outlined some of the biology that exists here, but this blocks PD-L1 as opposed to PD-1. And there's a phase 1 study that's been looked at quite extensively across a number of different tissue subtypes: kidney cancer, melanoma, lung cancer, a hodgepodge of other diseases, and finally bladder cancer. And I'm going to focus actually on the bladder cancer patients that have been reported to date from this experience. So again, this data, if it was unprecedented in the context of kidney cancer, is just absolutely overwhelming in the context of bladder cancer. This is in a population of patients that have received prior therapies, and we're really seeing some outstanding and deep responses, which we're not used to seeing in the second and third line setting for this disease. And here we actually see a much more logical continuum between PD-L1 expression and response. So what we see here is that as you increase the extent of PD-L1 staining, 0 being very low staining, 3 being high staining, you have this progressive rise in response rate from 8% to 17% to 48% to 60%. So my take home here is that PD-L1 may have more utility in bladder cancer as compared to kidney cancer. I would caution that this still needs to be confirmed. I wouldn't rush to stain every patient for PD-L1. But perhaps the utility of PD-L1 staining is really disease specific. And finally, as a last consideration before I wrap up here, I'd suggest that PD-L1 may potentially be dynamic. We've had a lot of really outstanding dialogues over the past couple of months suggesting that PD-L1 status may change over the course of time. It's really key that we potentially get biopsies prior to study entry as opposed to relying on old archival specimens. This is an example of what we did in the context of the PD-1 studies that I outlined earlier in kidney cancer. So a patient may have had their kidney tumors resected years and years before they actually have a diagnosis of metastatic disease. But nonetheless, when we're looking for PD-L1 staining, we're looking at that tissue that was acquired years and years back. So perhaps that's not truly representative of the patient's PD-L1 status at the time they want to enroll in a trial of nivolumab or 3280 or what have you. So it's going to be really key for us to really get up-to-the-minute data with respect to PD-L1 status, and that can only be done through biopsies. And again, I wanted to highlight that study that was presented at ASCO this year. Your friends, colleagues may potentially be approached with study designs like this one. And I think I always sense some apprehension when I present a study that includes a biopsy at baseline and several weeks into therapy. But unless we have studies like this that are conducted, we're really not going to make a lot of ground in terms of understanding the true role of PD-L1 status in terms of efficacy. So again, my take on the data here is that biopsy-driven studies certainly are a sacrifice on your behalf and on the behalf of all patients enrolling, but they really are going to potentially provide us a more accurate sense of PD-L1 status. So I'm going to summarize here by telling you how this conversation ended. So again, we'd had this request from my patient's son, who's an outstanding immunologist, to get some tissue stain for PD-L1 expression. And what I had to tell him is that we're not quite there yet. Let's look for a clinical trial. And we have a whole host of clinical studies that are ongoing at City of Hope and other academic centers. Not all of them are necessarily in the context of PD-1 or PD-L1 therapies, but I would encourage participation in clinical trials above all else in this context. Thank you.